Hey, it's Dr. Amanda with Straightsmile Solutions, straightsmilesolutions.com, and today we're going to talk about that kind of one-off situation when you have a patient who's clearly class 2, but the class 2 is not due to a small mandible, a small lower face. It is due to a large mid-face. That's okay. So this is, I kind of did some graphic art here of my own because I couldn't share the actual records, but this is what I wanted to show you. I mean, in those type of cases, you're going to see this kind of, without seeing the ceph, just looking at the face, it's going to look like a class 2 profile. It's going to look like a weak chin. You might see this little like curled down lower lip, but you're also going to see a pretty, acute nasolabial angle, and you're going to look that and go, oh, face doesn't look good. What should we do orthodontically to make this better? Well, first thing you're going to always want to do, as you do with any situation where you have an AP discrepancy or even a transverse discrepancy where you're like, well, should I make things bigger or smaller, is find out, well, how are we right now? Baseline, let's do a sleep screening. Let's do a myo screening. How are we? Is there space to put our tongue on the spot where it needs to go? Is the child or is the patient able to breathe through their nose? How is the airway volume? So you want to do all that kind of screening. And if you don't know how to do that screening, it's okay. We got lots of help for you in our courses, in our YouTube channel. Of course, you always want to check and see what's legal in your country or your state of licensure, what is standard of care. But ultimately, that is the goal here. So if you look at what a ceph would look like if you took the x-ray, you would see that these incisors are crazy inclined, probably these lower ones as well, maybe not, but definitely the uppers would be, and almost in a dangerous spot for trauma or even for long-term perio. So the goal is going to have to be to, instead of growing this jaw and bringing it forward, and I feel like so many of us are kind of brainwashed that that's always the best thing, that's always the right thing. No, it's not. Sometimes you don't fix a problem by doing it the wrong way, by doing it the opposite way, just because that's the most common way that people do it. You have to find out the problem at its source. So it might be involved. You might take out 4 teeth on this case, or you might take out 2 teeth, or you might take out no teeth, and maybe do some IPR and some expansion. It really comes down to how that particular patient is. But we want to put the incisors in a healthy situation so that they'll be stable for a lifetime, so they're not going to be falling out when the patient gets older because we put them in an unstable, unhealthy situation or a situation where they're prone to trauma or even speech issues. If I had to guess, a patient like this probably has speech issues. I had speech issues, and you can still hear them sometimes. Even though I've had my myo fixed, I've done through speech training and everything, but occasionally because my incisors were not corrected properly at the right time when I was a kid, I developed speech issues. So they're still there. So anyways, all right, thanks for listening. And learn about cephs, definitely. But also look at the patient's face and just look at their total body health as a whole. We want to orthodontically give them the most harmonious looking profile, but also a healthy profile. All right, thanks.